So we're outbound, so what we mainly do, we're the ones that, we're like the first point of contact for new patients.
Okay.
So for us, we try to really get them to schedule the appointment by whatever means according to Danielle.
Okay.
No, but, we're the ones that we speak to them and try to get them to schedule the appointment. So
Now that's before they come to the door, or after they come to the door, get them back into the door?
We have
Before.
PCP referrals.
Okay,
So
gotcha.
PCP
Marketing.
referrals, marketing, Facebook, the
And-
commercials.
Okay.
Actually both. So we do reschedules as well.
Okay.
Once they've been through the door.
So both of them?
Yeah.
Okay, well, that's good, and so that's why this will be, I think it'll be helpful, because a big part of, and you guys know more than I do, but I think a big part of getting a patient to come see us is them understanding that there's something that we can help them with. And so if you're able to kind of talk to them in their language, but really explain that why we can be helpful, I think those are things that would help them want to come. So hopefully I'll try to cater, I'll give you an understanding of what the pathology is and what's going on, and then what we do to try to help with that. You guys, most of you guys know me. You know, I'm Shah. They brought me in. I'm primarily the men's health specialist, and with Dr. Hackey leaving, I do the vast majority of the men's health here. So what is men's health? Men's health is really anything for men. You know, it includes PSA checks. It includes enlarged prostate treatment. Okay, but and those are things that all urologists do. What makes men's health specialists unique is that I do a lot of the things that not all urologists do, like erectile dysfunction, which everyone treats, but when it comes to complex erectile dysfunction with penile prosthetics, things like that, not everyone does that. Testicular pain, most urologists will, they can give you some ibuprofen or do something like that. But if it comes to microsurgery for that, and we'll talk a little bit about that, that's something where a specialist would come in. Infertility, those are things where, especially when it comes to microsurgery for infertility, those things where men's health specialists would come in. So expediting a patient's care. If they go to a general urologist, they'll still get great treatment, but then they may eventually get referred if it gets to a point where they need a surgery, versus getting them straight to the person that does this. If they need a surgery, they can get scheduled right away, and that's one less step you have to worry about. A patient coming in, and then not only coming in, but then leaving and having to go see somebody else. If you can get them directly to somebody else, it may save you a step, save you some effort, and make it more likely the patient stays.
That's a good selling point. So you're saying like regular urologists, they can't do certain surgeries. It has to be a
Right.
specialist.
Well, it depends, yeah. So they may not be trained or comfortable with doing certain surgeries, and we'll talk about some of those surgeries
Okay.
Today. Okay. All right, and feel free to ask questions at any point. Again, this is for you guys. So if you think of something, don't feel shy about interrupting me. We'll have in between each thing, we'll have points where I'll ask you if you have any questions about it. And that's a good time to ask as well, but if you're just dying to ask something and you're worried you're gonna forget, just ask, it's okay. All right, so a little bit about me. For those of you that don't know me, I was born in India. I was only there a few weeks though, I wasn't there very long. And then I went down to Africa. I lived there for a while. I bounced around from location to location. I started in Zambia, went down to South Africa, I was in Botswana for a while. And then eventually made my way over to Chicago. My sister was born in Chicago. I was there for about a year. And then went down to Tampa. I grew up in
Too cold.
Chicago was cold, yeah. The Windy City was very cold.
You can't go from Africa then to Chicago.
Yeah, exactly. Because I couldn't handle the cold. So I went to Tampa. I went to high school there. And then I went to Gainesville, the University of Florida, which happens to be the greatest university on the planet. For my undergrad training, I decided I did like the cold a little bit. I went back up north, went to Ohio. Did med school up there, met my beautiful wife up there. And then I missed heat again, so I came back to Tampa, did my residency there, had my first kid there, and then eventually made my way to Atlanta for this job. We just had our second kid, Thank you. And so that kind of brought me to where I am today. And everyone kind of asked, why would you, of all the things that you want to do, why is it that you chose men's health as your treatment of choice? And I tell them, look, it kind of my path kind of just revealed itself. And so that's what kind of brought me here.
I thought it when I worked in the city. Like the regular person in the
So that kind of brings us to this whole men's health thing, okay? The one topic that you definitely wanted me to touch on is erectile dysfunction, so we'll spend a lot of time on that, and then I'll quickly touch on a few other things that we do in men's health, okay? So erectile dysfunction, what is erectile dysfunction? It's essentially an inability to have an erection that's sustainable and efficient for sexual intercourse. And so what does that really mean? An inability to have an erection? Yeah, maybe. An inability to keep the erection? Yeah, maybe. And it's essentially if a patient is unsatisfied with his erections, that's erectile dysfunction. So they may be able to have and maybe maintain it, but they just feel like it's not like what it was before. Well, it's still worth getting evaluated, okay? It's important to explain to patients that they're not alone. Erectile dysfunction is, for a lot of patients, an uncomfortable topic. They don't like talking about it. They feel like they're alone in the world because they don't want to share that information. So, to be able to tell them that 1 in 4 men have this, there are 30 million men out there that have this, that may be important information. A lot of primary care doctors will tell them, hey, listen, it's a normal consequence of aging. You're getting older, you deal with it. Not necessarily true. Aging, the comorbidities, and we'll talk about that come with aging, do increase your risk for erectile dysfunction, but that doesn't mean just because you have erectile dysfunction and it happens with aging that you should do nothing about it, okay? So there's 2 general types. There's a psychogenic cause of erectile dysfunction and an organic cause. All the psychogenic part means is there's a psychological component, whether it's performance anxiety, stress, family stress around, a lot of things going on, a family member just died, relationship issues, things like that. Younger men, 20s, 30s, tend to have more of a psychogenic component. Organic means there's actually a physiologic cause of this, okay? Whether it's blocked arteries, venous leak, we'll talk a little bit about these things, nerve issues, okay? Any of these that may be contributing. Sometimes it's a combination. And one of the things we do is called a penile Doppler, okay? What the penile Doppler does is that we artificially give an erection with an injection, and then we look at the blood flow patterns, and we can see if there's a blood flow blockage, or if there's what we call leakage, where the penis can fill up with blood, and that's called an erection, but it leaks right back out through the vein, so you have leaky valves. And that's called venous leak, and that we can diagnose that using a penile Doppler. So these are some of the things that we can do in clinic, especially when you have a patient where you suspect there may be a psychogenic component. If the penile Doppler is completely normal, and they already have all these other reasons to have that, you can say, look, I think you would benefit from seeing a sex therapist, things like that, okay? So how does the erection occur? There are many steps to an erection, okay? Everything kind of starts with the brain. So essentially, you can see the brain up there. Oh, there it is. Okay. So there's essentially everything kind of starts with the brain. What happens is the brain has to be stimulated, okay? When you're stimulated and you have that urge, that desire to want to have sex, then it sends a signal down these nerves. Through these nerves, it tells the penis, hey, I'm excited, give me an erection. And really what it does is it releases this thing called nitric oxide. Nitric oxide swells blood vessels. You get increase in blood flow. You get this rush into these corporal bodies up here. So there are 2 bodies inside the penis. Right here, you can see 1, 2. Those fill with blood. And so you can see how they're not filled with blood here, or much blood, and now they're filling up, okay? That's called an erection when you get nice, strong swelling of those that giant corporal body, that giant blood vessel. Okay. What happens is when this fills up, it squeezes these veins right here shut. By squeezing the veins shut, okay, because it's so swollen, blood doesn't leak back out. So you're able to maintain the erections. If you don't get a good erection, you get half an erection, you can't squeeze those veins shut, so it leaks right back out, okay? If you have leaky veins, it leaks right back out. That's called venous leak, okay?
And same thing with swollen.
Yeah. So that's, so that's essentially the mechanism of erection. So any problem here, okay, what can cause problems, okay, and cause erectile dysfunction. And so part of the planning and discussion with the patient is, hey, what are your risk factors? What are the possible causes of your lack of erections? And so what are the causes? So number one, everything starts with the brain, right? You have to have that urge, the desire, the stimulation, the sexual interest, and there are lots of things that can impact that. Lack of stimulation, stressors, we talked about that. Low testosterone can actually decrease your sex drive, okay? If you have decreased libido, decreased sex drive, that can impact it. Medications, there are a lot of medications that can actually, any psychogenic medication can impact your urge and desire to want to have sex. Poor self-image, right? Another psychogenic component. But let's say all of that's intact. So a lot of these patients will check a testosterone level on, right? And to make sure that their testosterone is normal. And it's not normal, we can treat it. Let's say that all of that's normal. Well, then the next thing we would do is look at the nerves, right? We do something called an EMG, which can kind of give us an idea of whether the nerves are firing okay. Things that can affect the nerves. Anybody that has diabetes, you know, patients with diabetes, they eventually will lose sensation in their legs, their arms, they get tingling, nerve problems, all diabetes, right? And so it can affect your nerves, and so it can affect that signal pathway. Back issues, so spinal surgeries, pelvic surgery, so patients who had a prostatectomy for prostate cancer, they had a prostate removed. The nerves for the erections actually run right around the prostate. So when you remove the prostate, you're actually hurting those nerves. Advanced age, okay, you get nerve breakdown as you get a little bit older. So let's say all of that's intact. Well, the next thing is the blood flow issue, right? You gotta have good blood flow into the penis to get an erection. So, things that impact blood flow. Anything that can cause heart disease, okay, can cause plaque formation in your vessels. Those can cause blockages, and they tend to block the smaller vessels first. Well, guess where the smallest vessels are? It happens to be the vessels that feed the penis, okay? Erectile dysfunction can be a precursor for heart disease, especially if it's a arterial blockage issue. So a lot of patients will get erectile dysfunction before they get a heart attack, okay? And that's because it blocks the small vessels before it blocks the big vessels, okay? So diabetes is a risk factor for heart disease, okay? It increases your risk for plaques, for blockages, things like that. High blood pressure, risk factor for heart disease. Obesity, risk factor for heart disease. Heart disease is a risk factor for heart disease, right? Vascular problems, right? You have blockages in vessels, so that's an obvious one. Pelvic surgery, including a prostatectomy or removal of the prostate. You're tying off blood vessels so they're not bleeding, so thus you're destroying blood vessels that are feeding that pelvic area, including the penis. Advanced age, okay? Radiation destroys blood vessels, okay? So radiation can cause a decrease in blood flow. So all of these things are risk factors for heart disease, okay? And thus risk factor for erectile dysfunction. I think this thing is dying on me. Let me try this again. Oh, there it is. Okay.
Dr. Shah?
Yeah.
If you remove the prostate, does that patient then automatically qualify for an IPP?
No, not necessarily. So the way, and I'm working on developing what we call a penile rehabilitation protocol to try to improve the likelihood that they get their erections back. Typically, they say you should meet certain criteria. Like you should be a certain time period out from the surgery, or it should be pretty obvious that you're not going to recover your erection. So if they had erectile dysfunction prior to for their prostatectomy, they're probably not going to be any better than that. So if they were likely to need an implant before, they're probably gonna need it after. If they have absolutely no improvement by, let's say, 3 to 6 months, then they probably would qualify. And if we do a penile Doppler and shows venous leak, there's plenty of data that shows if you have venous leak, you're gonna be one of those people that will probably need a penile implant. So there are certain things we can do to expedite it, and that's what I'm developing protocol to kind of get patients quicker to where they need to be rather than having to wait 2 years before they can get there. Because that can be a lot of frustration for a patient, waiting 2 years before they can really have sex, or 2 years and they're leaking, and they're miserable, and we're trying to improve the quality of life of these patients. And so we're trying to, so what I'm doing is we're working on ways to expedite that so we can get them where, if they're gonna end up needing it anyway, let's get them there earlier, okay? That was a good question. All right, so treatment options for ED, and so this is what patients really want to know. Not so much as what the cause is, but more so what can you do for me, right? And so the treatment options always start with oral therapies. So Viagra, Cialis, Levitra, Stendrol. What these medications do is they talk to the nerves. They tell them, hey, increase that nitric oxide even more. Increase that nitric oxide and swell those arteries. That way, if there's a blockage, maybe you'll swell it, pump more more fluid in there, or blood in there, and squeeze past that blockage and get a better erection, okay? So that's the concept behind PDE5 inhibitor or Viagra, Cialis, Levitra, Stendrol. There are potential side effects. You can get headaches, you can get blurry vision, you can get upset stomach, you can get back pain. Not everyone gets it, but if you do, then you can tell them, hey, we can either switch you to a medication that's less likely to cause that, or we can just stop the medication and move on to the next step. But almost every patient will start with oral therapy, okay? Because it's the simplest approach. There are patients that can't get oral therapy, including patients that have a history of heart attacks, heart disease. So if a patient says, hey, I saw my cardiologist and they just don't think it's safe to get that, we can still help them. In fact, a penile prosthetic is an option for somebody who can't take this because of heart disease, right? Because it's a mechanism that does not require them to put any kind of medication into their body that could hurt something else, okay? So in about 30 to sometimes rates as high as 70% of patients, especially patients with diabetes, this will not work, okay? And so there are going to be a lot of patients where they need to move on from this step, but we do try this in just about everybody. Okay. Dang, this thing is.
I have a
Yeah.
quick question. So let's say someone gets on the oral therapy. How long, I mean, is that something that they can do for long term, or is this
Yeah.
considered, oh, they can?
They can, yeah. Yeah, keep taking it, as long as it's working.
Okay.
Yeah, but there's a cost to it. So the pills used to be like as high as $100 a pill.
Yeah.
And it went generic, Cialis, Viagra went generic about 2 years ago, and now it's about $5 to $10 a pill, which is cheaper, but that's still very expensive. So every time they want to have sex, they have to pay $10, you know?
Oh.
So that's right, that's prostitution. Yeah, so sildenafil is the same thing as Viagra, it's the generic version.
Okay.
Yeah, tadalafil is the generic version of Cialis. So, they're generic, those are the generic versions available now, at a cheaper price, and they tend to work just as well. Some patients say the brand seems to work better, others don't, so, yeah.
Yeah, this picture's stressing me out. Do you guys numb it before you inject it?
No, so we'll talk about injections. So the way,
Good to know.
so the way the injections work, right, is this needle looks more, just to make a point, it's bigger than your average needle. It's a diabetic sized, tiny, tiny, tiny needle. To numb it, I have to put a bigger needle in to numb it, and then I stick it. So it doesn't make much sense, right? It makes more sense to just put it in. Yeah. So numbing it would be more painful and then there's the burning of the numbing. So the numbing would be more just uncomfortable than just putting the needle in. This is what we give to induce that erection to get it to do the ultrasound. And there's a couple reasons why I have patients do it. All patients that failed medical therapy, or the oral therapy, I encourage them to do this at least once. There are a couple reasons. When I tell you or anyone else, hey, I'm going to put a needle in your penis, they say, I'm done. Right?
I'm done.
I don't
Definitely
Right, and so that's why, and then it's even worse when I tell them, hey, I want you to put a needle in your own penis, right? So what this does is, one, it gives them exposure to what it's truly like to actually have the needle put in, and we do it ourselves. And it's actually not as painful as mentally it seems, okay? Or uncomfortable, because it's a very, very tiny needle. Two, they get an idea of how well this works. And three, we get an idea of the dosing. And then four, we can do an ultrasound and figure out the blood flow and the actual diagnosis of why they have erections, right? And so that's why we do this, and this is why I encourage it. It can also tell us if there are any curves or bends or abnormal anatomy to the penis, so we can treat that and fix that, okay? So there are a lot of reasons to do at least the ultrasound with the injection. There are a few problems with the injection. One is it can be painful, right? It can be uncomfortable. For some patients, they tolerate it better than others. Two is constant insertion of needles can cause scar tissue formation. We call that Peyronie's disease, okay? Number three, if you get too excited and you inject too much, you can get an erection that lasts too long. That's most guys like, oh, that's great. That's not great. That's a medical emergency. You have to go to the ER, and sometimes they have to put needles and try to drain all the blood out. So there are problems with this, and that's the reason I always have them come in, and first we try to dose them appropriately before we go ahead and have them start just randomly injecting themselves. And then so those are the reasons to do and to not do injections, okay? But I have everyone at least try it, because at least they know if they can tolerate it or not. And then two, insurances require you to go through a lot of these. A lot of them require it, and so you can at least say they've tried it, and either they did want it or they didn't want it, but they've at least tried it, okay? So it crosses that off the list for insurances, all right? Vacuum erection device. This is a cylinder that you put over the penis. You essentially push a button or use a handheld pump. Penis pump. Penis pump, and you increase the vacuum effect, pulls blood into the penis, and then you usually keep a rubber band around that cylinder, and you slide the rubber band off down to the base, and that pulls the blood in there, okay? And so then you can use this for sex. The good things about this is you don't have to worry about any injections or putting medication in your body, so it's drug-free, okay? You don't lose much by doing this. You can get a little bit of bruising, especially if you're on blood thinners. And if you've ever put a rubber band around your finger, you notice it starts turning blue and has that numb feeling, you get a little bit of that, and guys don't like that. And then because of the banding, when they ejaculate, it kind of blocks sometimes the ejaculate, and guys don't like that either. So there are negatives to it, but it's not harmful, and it's worth trying. And it's important to at least talk to them about it, and every patient should know about every option. The good thing about this is actually a lot of stretching. So before, a lot of patients are concerned about size, and you can lose size after a prostatectomy. So by getting them on this, at least temporarily, it tries to preserve that size and maybe even get them some of that lost size back. Yeah.
Do we provide the patients with this?
A good question. So right now, we do have them, but they have to purchase it. I'm working on a protocol where we can get these for a more cost-effective price, and any patients that had either a prostatectomy or potentially, or are going to need a penile implant, we would potentially provide this either at cost or cheap or free to try to get them,
So insurance
encourage
does
them to
not
use
cover
it.
that.
What's the cost?
They sell them at the sex store.
They're, we sell them between $150 to $300. Most patients won't pay $150 to $300 for it. So I'm trying to get it down to either, I don't know the pricing right now, but they're much more affordable, or for select patients.
But you gotta make your own.
Yeah.
Make your own?
Yeah.
Yeah.
Well,
Has there ever been an instance where the rubber band comes off during intercourse?
No.
Yeah, I mean, it can slide off. It's not, I mean, it's a pretty tight band. It can slide off. You can still, even with the rubber band, you can lose your erection. So it's not a perfect science. The rubber band's not a condom, if that's what you're asking. It's just a rubber band at the base. Okay, so, yeah.
Available, is this in consult?
Oh, for training? No. Yeah, so we do, when we give them the vacuum erection device, there are pretty self-explainable instructions, but sometimes we actually pull it out and we say, well, this is how you pump it up, instead of we talk them through how to use it.
Okay,
Yeah. We usually just do it when they're in the office, yeah.
They're not laughing about, they're laughing about her.
Oh. Okay, insertable drugs, okay, things like Muse. These are kind of like the stuff you inject, but instead you put a pellet in the urethra. This is probably the least used method, and the reason is because it can cause a lot of burning and uncomfortable or discomfort. I use it in select patients who are really hesitant to go down the penile implant route, but keep getting priapisms or some other problem with injections. So middle ground would be something like this. And then we use it for some other reasons too after penile implants, but in general, the goal of this is to increase blood flow, similar to the injections, but just another way to do it.
What is the pellet though? What is it?
So you insert, it's a tiny pellet or a gel, or there are different types that you put into the urethra and you insert it in there, and then you essentially rub the penis trying to increase friction and get it absorbed. The absorption should improve the penile, just similar to the way the injections do, increase penile blood flow.
But what kind of medication is it? What does that mean? So the medication.
So it's called alprostadil or Muse.
Okay.
Okay, that's the name of the medication.
Oh,
Muse is
okay.
the most commonly known name for it. But and so
Oh, that's what I
I know
was
it's
saying.
in
We scheduled something, we scheduled.
no, so these aren't things we schedule. These are things we prescribe. So yeah, and I'll tell you that there are not many people that prescribe this. I prescribe it when indicated, but it's not a option of choice. It has the highest dissatisfaction rate out of any of these. And okay, so
Dr. Shaw,
yeah,
do you do any like cosmetic work?
I do.
Cause we've been getting a lot of calls and questions about that.
I do a lot of. I'm probably the only one here because Hacky did them as well.
Right.
So I'm probably the only one here that I can think of that does a lot of the cosmetic work. So we do things like fat pad excisions, essentially like penile elongation type
We've
surgeries.
been getting calls about that, so we do that.
Yep, yeah, to some degree, yeah. I mean, there are some things where it's not worth doing because the risks are high, and you counsel the patient on that. But there are a lot of cosmetic work where we do things like that. Yeah.
Is that like the micro penis as well? Is that what they do as far as, because I've gotten that call as well.
Yeah, so it depends. So there's buried penises where we'll do buried penis repair, and basically it's almost like moving skin around to decrease the fat around it and increase the appearance of the penis. Micro penis is a little bit different. It's a very small population. Some people think they have micro penis, but they have normal penis. And so, but yeah, you can send all that, and you can appropriately counsel.
Yeah.
Okay.
I do have a,
Cosmetic work, yeah, all of that's cosmetic work.
I do, we have getting a weird call that actually he was on it, where, someone, I don't know how, but part of his can come off.
What?
And his penis, and he wanted us to put back in. He had already went to the ER. He didn't want them to do it. He wanted a urologist to do that,
Yeah.
to fix that.
Yeah, usually that needs to be done within like 6 hours.
We kept telling him to go to
Probably
the ER.
electively not a good idea. So yeah, now you did the right thing sending him to the ER, and the urologist at the ER could potentially do that. That's something that can be done. Yeah.
Testicular implants.
Yeah, so I do all that. I do testicular implants as well. I did a handful, I think, already over there. A lot of patients that have lost their testicles or will be losing their testicles, and I give them the option, all of them, or we can do down the road, one or the other. But yeah, testicular implants is something that comes under the whole men's health specialist thing.
Just a suggestion, when you do get those calls like that, you can always text Dr. Shaw or I to say whether, yes, this is a patient, just so we don't lose any patients in the meanwhile.
Yeah.
Because
The one thing we want to avoid is giving patients a runaround. So if they go to one provider, send them to another provider, send them to another provider, by the time they get to the third provider, they're probably never going to go. So we want to, and remember, every time they go see another provider, the question's like, hey, do I need to pay a copay? When patients have given the runaround, they come see me, I tell them, hey, we're just going to waive your copay for today. Okay. It's because it's a big burden on a patient to not only constantly move, but every single time they see someone, they feel like, hey, I'm paying out of pocket, I'm getting nothing out of this, right? So if we can get them to the person that can help them the most quicker, I think it's a win for the patient and win for us. All right, so then we go to the penile prosthetic area. And so there are two general types of prosthetics, okay? There are penile prosthetics. There are ones that go inside, so those two corporal bodies I told you about earlier that fill with blood. The problem is they're not filling with blood, right? So what we do is we insert a mechanism for them to kind of use that body, inside that body, okay, so that they can still have erections. One type is the malleable, so these are rods that stay inside, okay? And the good thing about them is they're always ready to go, they're always up. The bad thing about them is they're always ready to go and they're always up, right? So they're more cost effective for self-pay patients. It makes more sense. They're very, very, very functional. They're very bendable, so you can keep them up against your belly, so they don't have to be noticeable. Okay, and some patients actually like this more than the alternative, which we're going to talk about.
So it never goes down. I'm sorry to cut you off. It never goes down.
Never goes down, and you know it's bendable, so we call them semi-rigid because they're strong enough where you get a great erection and you can use it, but they're bendable enough where you can conceal it and it's not bothersome. Okay.
Where do you insert it? Like
Inside these
bottom?
corporal bodies.
No, I mean like.
Where do I make the cut?
Yeah.
So there are 3 different places I can make the cut. Most urologists will do 1 or maybe 2 places. I do all 3. Just depends on the patient and their anatomy. You can make a cut down here in the scrotum. I can use the circumcision incision. So some of them will say, hey, I want a circumcision at the same time. Well, I'll use that same cut and put everything through there. Or you can put it up, make a little cut up top. For most of these pure rods, it will be a cut up here, even over their old circumcision scar. So if it heals, you never know anything was done. But you can use any one of the 3.
What's the self-pay price? I know for the other one, it's like 18,000.
Yeah, for the inflatable, it's 18,000. I think this one runs somewhere around 8,000.
8,000.
Oh, it's a big difference.
So it's a big difference, yeah.
So when a patient calls and they say, I was there this morning, I had an implant, blah, 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 blah. And they're like, I can't get it down. I need to see someone. I've gotten a lot of those calls in the past.
Yeah.
Is that you that will take care of that? Will there be a
So whoever put
nurse?
the implant in, typically, and if it's it's not us that put it in, then they can just come to me or any provider. Typically, any urologist will be able to take it down. You can send it to me. That's fine, or anybody else. If someone put it in, it should be sent to that person. If that person's not available, you can send anyone. It's not an emergency.
I was going to ask you.
It's
So
not
it's
an
not.
emergency if
Okay.
they can't get down an inflated implants, okay? It's not harmful, it's just uncomfortable. So you don't have to make an appointment today or
Okay.
send them to the ER, okay? So they can you can make an appointment in this week sometime, just so that I'm not uncomfortable. You can send a telephone encounter for something like that, and you can have someone call them back. Things like that are perfectly reasonable, yeah.
Will there be like any blood in the urine after this or?
Should be.
Should it
So
be?
sometimes, because I do put a catheter in when I do the surgery,
Okay.
and I pull that out, so maybe from that, but typically they should not have blood in the urine. This is a completely different channel.
Okay.
So urethra is this thing here, and you can see it's completely separate from these, and if I'm in the urethra, that's a problem. It's a problem, yeah.
Does that, the implant, does that cause infertility or
No.
are you?
So it does not,
infertile?
it should not impact your ejaculation, it should not impact your orgasms, it should not impact your sensations. All that's intact, all it really should do is give you a good erection.
Is there an age limit for this?
As in too old or too young?
Well, I've seen guys that are like 71 and they're getting
I've put it
this.
in 90s and
Oh, yeah.
90-year-olds, I think the highest is in the 90s.
Oh, okay, so.
I don't think I've hit 100 yet, but I put it in healthy 90-year-olds, I put it in young 20s and 30s. It's not typical, I don't like doing that. But patients who have these recurrent priapisms, that's a group, a younger group where they sometimes need it, yeah.
What's the difference in the downtime between this one and the other one?
This one, in general, any cut I make in your body, we say 4 to 6 weeks to heal. To be honest, this one probably heals a little quicker because the incisions are smaller. It's a quicker surgery. So, this one's probably more like 3 weeks. But I tell everyone 4 to 6 weeks because, you just don't want them to get crazy. Yeah.
How long does that last? Is that something you have to go
No.
and redo every 5 days?
No. So this one, there's no mechanism to it, right? There's no pumping, there's no tubing that can break down. It's just purely a rod. So in theory, it can last as long as it lasts, okay? It's possible that because it's more rigid, you can have things like erosions where it just pops out or something like that. Not common. If it happens, we just pull it out, we let it heal, and we put a new one back in. So there are things that can happen, and that's with any implant in general. But typically, it'll last somewhere around 10, 20, I don't know, years longer. It doesn't really, you know, it may break down over time or something like that, but it's not common.
Is there, oh,
You're
sorry. Is there
Do you-
different sizes?
Go ahead, Karina, go ahead.
All right. Bring it up.
Different size.
No, the different size.
There's different
So I measure
sizes,
your,
okay.
I measure your length and I measure your girth
Okay.
when I put it in, yeah.
Now, because this is a rod, can it break? Can they have that type of issue with it?
Yeah, I've never seen a break.
Okay.
You know, you can imagine if it breaks, you're probably gonna have to break your penis to break the rod. So I've never seen a break, and you know, I do a lot of these, so I'd say it's pretty low likelihood. Yeah, they're pretty stable, and it's not like with a penis you just like tear them, right? That's not a thing. So they're pretty durable. The alternative is inflatable. So the inflatable, same thing. We put the cylinder in here. There's a button or a pump in the scrotum, okay? And there's a little reservoir in this area called the spacer retius. It's an area near the bladder that has just fat in it. So we put it in there. I do all of this work through a small incision. So, and again, same 3 incisions, right? I can use the circumcision incision, and that's it. Only incision in your body. A small cut up here, or a small cut in the scrotum, about that big. And I put all of this through that one cut. So it looks like a lot, but when they're done, you don't see any of it, right? It's all hidden. The biggest trick is a patient learning how to use it. They usually tend to find the button and learn how to pump it up pretty easily, but the calls you're gonna get are, hey, I can't get it back down. And that's because they haven't quite figured out or mastered the ability to deflate it. What I do is, the first 2 weeks I actually leave it about 70% out because it stretches, and stretching actually increases girth and size. Then around the 2-week mark, I teach them. I have actually a patient educator, so a person who actually has the implant themselves, come and teach them and spend a whole hour with them, showing them how to use the device, because I really want them to know how to use it, but they're not ready to use it, so I want them to start pumping it up and pumping it down every day, usually 2 to 3 times a day, okay? And so we start having them cycle it so that when they come back in about 2 or 3 more weeks, they already know how to use it and they're ready to use it, and I can give them the clearance, and then they can go ahead and use it. So that's essentially the way my follow-ups work. So yeah.
I know you said you measure everything. I have had some patients call in and ask, how long can we make it? Can we make it super long? Like, so what would your
So there's something called stretch penile length, where we can literally stretch the penis, put it on full stretch, and we measure it. That's gonna be your length. Now, that being said, if you leave, at least with my implants, if you leave them inflated, what happens is the stretching of that can actually improve the length a little bit. And I try to give them a little bit more length in hopes that, knowing that they're gonna stretch a little bit and try to regain some of that lost length. So we do try to do that, and there are some patients in 3 to 5 years will come back and be like, hey, I think I gained some length, and we'll take it out and put a new one in, and then, hey, they've gained 2 or 3 centimeters, and we put a bigger implant in. So, okay? So a lot more stuff to it. There's tubings and pumps and, you know, reservoirs, and so there's a lot more stuff that can break down. And so that's why this, somewhere between 5 and 15 or 20 years, typically it may break down, and if it breaks down, then we would just remove and put a new one in. Okay?
Do you think the use of it often would cause it to break down sooner?
Maybe. It may impact the rigidity of the implant, so potentially, but not necessarily. I mean, if they're using it often and they break it, I think that's a good thing. All right? So I think they won that one. Like I said, this is more expensive. You know that it's $18,000 out of pocket. So this one tends to be more costly. So out of pocket for self-pay patients, it can be more expensive. And we can always pull the other one in and then swap it out for this. So if a patient says, I may have insurance in the future, I don't know, but they can always go with the rods, and if they don't like it or they feel like, man, I really want the inflatable, when they get insurance, they can always go down that route. Yeah.
If they're not having any problems, is this like an annual appointment that they would need to schedule?
With the implant?
Yeah.
Honestly, if they never came back because they're doing so great, that's fine, and they can come back as needed. So I do see them manually, just to kind of make sure they're doing okay, but it's not mandatory by any means, and if they feel comfortable with it, like, I'm doing great, I say, hey, just come back as needed. Yeah. Yep.
Are their testes removed?
Nope. No, it's hidden in there. Yeah, they're all three, so they technically have 3 balls. But you can't see them. You can't see them. Yeah.
So I've seen the one we have in clinic,
The device, yeah.
Yeah, so I've seen that one.
Yeah.
The one that goes in the scrotum, the one at the bottom, is hard, yeah, the pump is hard to pump.
Yeah, and it's on purpose. You don't want them to sit down and accidentally like bump it up into something inflated. So it's intentionally made so that it's not the easiest thing, but not the hardest thing to.
Is it painful?
No. It's right under the skin. So that area in the beginning they may have some sensitivity because they're not used to it, but then that area just numbs and they do fine. There we go. So here's a model of it, okay? And so what you'll see is there's pump cylinder, which is inside, right? Running inside here. And then the reservoir, and then what they do is they find it in their scrotum and they start pumping it. And as they're pumping it up, you'll see that the water, which is the blue stuff, is filling that cylinder up, right? As it's filling up, they get an erection, okay? And it's good erection, it's a great erection, it's very rigid, it's very, 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 it's just in general probably better than when they were 20, okay? It's a strong, yeah.
So this procedure is technically for patients that the blood flow in the penis is not happening at all.
Yeah, for one reason or another, yeah. Or it's just not happening well enough. Yeah.
Right. Oh, so even if it's not happening well enough, you still do this process?
Yep, if their meds don't work and, we went through, talked about the other ones and for whatever reason they get to this, yeah.
So the reservoir, it looks like it's right there at your bladder.
It's very near the bladder, yeah.
So it doesn't cause any like bladder infections?
Not typically, yeah. Yeah. Now, if you go to someone who doesn't do very frequently, I have seen a patient come see me like a year or 2 later after an implant, and they're having a lot of urinary tract infections, things like that. Looked in the bladder, and someone had somehow put this reservoir into the bladder. So I have seen it, but that's the reason I empty the bladder before I put it in, so to avoid that, yeah.
And the reservoir is filled with water,
Saline.
saline.
Yeah.
So, and there's no risk
The-
of like it popping or
No,
anything?
and even if it pops, it's just saline, nothing will happen, yeah. But no, not typically. So we fill it with a certain amount, and not more than a certain amount, because that's how much these reservoirs are meant to hold, so.
And nothing about the pump is electrical like the SMS, right?
No. No electrical stuff, it's all just a pumping mechanism. Yeah. So the risks, we talked about these, erosion, which means it pops out of the skin somewhere, and in that case, we usually have to pull it out and let it heal and then put something back in. The chronic pain is pretty uncommon. Usually it's a sizing issue or something else. We can fix that. Device malfunction, like I said, eventually something may break down and we may have to swap it out. Infection, 1 to 3% risk. Okay, so, and if it happens, if you go to just any urologist, what they'll do is they'll pull it out and just send you to me. Problem is, if you just pull everything out, everything scars down. Lose centimeters of length, and I'll be lucky if I can get a super narrow something in there and try to work you back up. What I do is I pull everything out, I wash everything out with a complex wash. I spend about an hour just washing it out, and then I put something right back in. And so it gets them right back to where they want to be. Okay. Yeah.
So are you able to diagnose the device malfunction without taking it out?
Yeah.
And
Yeah.
would it be through ultrasound? maybe?
Sometimes, not so much ultrasound. Most of the time I can just tell based on feel, physical exam, and I can tell based on how it's pumping. I know the devices, I know where they tend to break, things like that. Yeah.
So if someone had one removed and they wanted to get another one, what I'm understanding is there's a large risk of scar tissue, they might not be.
If it's been completely removed, usually I can get something in, it just may not be as big or long as it used to be. Yeah, because what happens, that channel scars down if there's nothing in it. So the biggest, #1 risk of penile implant is if you change your mind, you're not gonna be able to have spontaneous erections later. So if you want me to pull everything out, no problem. If you change your mind, it's just gonna scar down and you'll probably never have erection again. Not that, I mean, that being said, the reason they're having an implant put in is because they're not really having erections to begin with. Alright, let's see.
There's worse things.
Yes, young man.
You ain't lived long enough.
Just wait.
I'm just gonna-
Suffering is.
Okay, so, insurances cover this, okay, important for you guys to know. So insurance is covered with the exception of maybe Medicaid, okay? But Medicare covers it, commercial insurances cover it, even Ambetter covers it, okay? So it is covered by almost all insurances, with the exception of Medicaid. Okay, so. All right, other men's health topics, so, keep in mind that not everybody, performs penile implant surgeries. Okay, so other men's health topics, okay? Low testosterone, you'll get a lot of that, okay? Low energy, fatigue, decreased sex drive. There is data to show that low testosterone can lead to heart problems. Low testosterone can lead to decrease in bone density, so it's bone count, okay? So there are benefits to replacing it, okay? There are signs, so those are some of the signs and symptoms that we talked about. It's pretty common, and it's a simple blood test to check if they have it. To treat it, in general, they can do injections, they can do gels, or they can do pellets. Most patients prefer the pellets because they come in, we put pellets under the skin, and then they don't have to do anything, and they get nice steady release for 3 months. If they do injections, you tend to get a sharp increase in your testosterone, so you feel great, and then a sharp drop in your testosterone. So by the end of the week or end of the 2 weeks cycle, you're feeling really tired again. And so that's the problem with the injections. The creams, the problem is they put it on every day, okay? Which is fine. You have to remember to put it on every day. And if it rubs off on your loved ones, your kids, your wife, right, it can be a problem. So that's the biggest problem with gels. So I'd say the minority of patients want the gels. And what you'll see a lot of is primary care doctors, because all they know how to do is either injections and or gels, and that's it. So that's what they get. And patients, when they call and they're like, oh, do you use testosterone replacement? If you talk to them about pellets or some other options, it's appealing to them when they understand that, look, with a pellet, you come to the office, we put it under the skin, and you don't do anything. It's a nice steady release for somewhere between 3 and 8 months. So yeah.
Is there a health risk to super high testosterone?
Yeah, I mean, so in testosterone in general, you worry about blood clot formation. So we watch your blood thickness, okay? You don't want to risk a stroke or something like that.
Is that in men and women, or just men?
Men, well, both. So we watch the same labs in both, but probably more in men because their testosterone levels are higher. In women, if you get them really high, they're going to start getting hair growth, you're going to start getting acne, things that they don't want. So in general, you want to, for women, to the testosterone level you want is around 50. For men, you want it somewhere between 500 and 800 if you can. So.
And for women, they would see the Urology for like something like PCOS, which is higher testosterone.
Yeah, and I do testosterone replacement in women too. So, yep, and there are not many guys that'll do that also. So I have a handful of women that I do pellets in. And so them, they do somewhere between 1 and 4 pellets. And men, we do start at somewhere around 10 pellets. So big difference in the number of pellets that we do.
So the pellets, are they gonna cost more than the injection?
So insurances cover pellets, okay? It depends on what they cover. So some insurance will say, I'll cover 6 pellets. Well, the guy probably needs 10 pellets. So they may have to pay out of pocket for some of it. We get them, there's a generic version of the pellets available, so we're able to get it for a discounted rate. Probably it'll still be about $50 a pellet, but if you think about it, let's say they cover 6 and they need 10, so they pay $200 for the extra 4, but it's once every 3 months. It's not on a regular basis. So I think overall, the cost will always be equivocal between all 3 options, okay? Just because insurance tends to cover a lot of it. Just depends on the insurance, et cetera. There's some insurances that cover all of it, all the pellets. What's that? Yeah. So, okay, here's the other thing. If they're young and they want to remain fertile, giving them testosterone, if I give you testosterone, like, hey, here, have some testosterone, your body says, hey, I have lots of testosterone, and it shuts down these brain hormones. Those brain hormones are what allow you to produce your own testosterone, one, but they also allow you to make sperm, two. So it shuts down your ability to have kids to some degree, okay? So if they're concerned about fertility, we don't give them hormone replacement therapy, but there are other options. There are pills that can actually boost those brain hormones, so maybe increase your natural testosterone. Maybe it won't get you to 800, testosterone 800, maybe get you to 400, you know, or 500, and good enough where you feel good, and you still are able to keep that fertility, okay? So there are things that we can do, and a lot of primary care doctors don't do that or don't know to do that, and so that's something that you could, if they talk to you about, you can mention, okay, especially if they're younger. Testicular pain, here's another thing that urologists in general manage. Torsions or emergencies or twisting, sudden testicular pain, send them to the ER, okay? But I have had 1 or 2 patients that actually showed up in my clinic with sudden testicular pain, and I untwisted the testicle, okay? So we took them immediately to the surgery center and untwisted it. You can also have epididymitis, which presents in the same way. Tends to be a little bit longer, but you know, the last thing I want you guys to do is try to differentiate between the two over the phone, okay? Yeah.
Yeah, we get a lot of referrals for that, and that would be the reason.
So if it's been like several days, it's kind of like a chronic thing, you can send them to us. That's called epididymitis. So that's an infection or inflammation of the testicle, and that we treat with antibiotics, typically, okay, and anti-inflammatories. Abscesses of the scrotum more often than the testicle, so just testicular swelling with some pain. Hydroceles, which is just swelling of the scrotum. Chronic testicular pain, and we'll talk about how we treat these. Varicoceles, which is these blue veins, an enlargement or engorgement of those veins, just causing this constant nagging, low grade pain. The treatment for a lot of these, so you know, antibiotics, anti-inflammatories for epididymitis, inflammation or infection of the testicle. A cord block we can do if we think it's nerve related. We inject lidocaine and we see if it gets better. The lidocaine numbs the nerve, so if it improves the pain, there's a good chance something surgical where we cut the nerves may do it. So that's a microsurgery. We use a microscope to do it, and I may be the only one that does it in this practice. So again, another thing where chronic testicular pain, and Dr. Hackey did do it as well. It may be worth sending it to myself or somebody that does microsurgery, because they'll ultimately probably end up that direction anyway. And then of course removal of the testicle, untwisting a testicle for torsion, all of us do that. If there's concern that it could be epididymitis or torsion, I would just send it to the person that can get it in the quickest, just to get evaluated if they're not going to the ER for whatever reason. So, okay, so if it's like a chronic thing or not sure, just send them to whoever can see them the same day. Okay.
Okay, but we do need to try to get them in the same day.
So I would say for testicular pain, and especially if you're like, man, it's really high. If they say it's like a 2 out of 10 or 3 out of 10 pain, not really that bad. It's been going on for a while. They can see someone whenever. If they say it's like, you know, it happened today, and I think there's a trauma and it's hurting, I have a 10 out of 10 pain, now to go to the ER or you get them in the same day. Okay. If they've said like it's been a couple weeks, you know, maybe send them same day just in case, that thing, because nobody likes pain. So. All right, infertility. So another thing where, you know, everybody does this basic workup, which is the ultrasound, the infertility labs, the semen analysis. Okay, the ultrasound is because the varicocele, which is that enlargement of the veins, is the most common cause of infertility in men, and that the treatment for that is microsurgery to cut those veins, similar to cutting the nerves. Semen analysis can kind of give us an idea of what needs to be done. Okay, and so the treatments are similar. You know, either microsurgery or you extract sperm, and you know, and then there are a whole host of other things that we do in the men's health realm. I think we overall kind of covered them all. And you guys look exhausted and need to go pick up your kids and stuff. So we're not here, but and what questions do you guys have? Yeah.
Okay, this is probably an off-the-wall question, but I have to ask it because you can't believe everything you see, like, everywhere. So I saw this, I think it's like a Q&A, basically it was like done on Facebook, it's a group, and, I didn't believe it, so I'm gonna ask, you're a urologist, so I'm sure you've seen it all, but there's like, some type of instrument, like a tuning, like a, kinda like a very thin, narrow,
Tuning fork.
iron rod, tuning fork, so to speak. And they come in a series, like they go from small to large. And apparently, people use this for sexual pleasure. So this gentleman stated that he had one that was inserted, and he wanted to see if he could do another, so he put 2 in.
Oh.
And one went through to the bladder. Is that logical to happen, like to go through the urethra and travel to the bladder, like for an instrument of that size?
He's a sadist.
So there are, if you're putting it in the urethra, which is the tube you pee out of, that tube leads straight to the bladder. And I have had, when I was training, there was a patient who was routinely, he was known, infamous, for years, we all knew him. And we saw his name on the list of patients in the ER we knew were getting called. And he would put pen caps in his urethra. And it would either find its way into the bladder or be stuck in the urethra and we have to fish it out. And so this became like a routine thing. So there are people who get sexual pleasure from
Pain.
not necessarily pain, but the stretching of the urethra. So there are different instruments out there and things you can do. These aren't recommended practices by any means.
I just wanted to see if you had seen something like that.
Yeah, I mean, I've fished, you'll be surprised at the stuff I've fished out of bladders, but yeah.
As far as, the infertility,
Yeah.
do you know, because sometimes you're not just working with the male, but you're also working with the female. Do you treat for female infertility?
I don't treat for female infertility. Typically, they have an infertility specialist for the female side. And so I do refer patients to the infertility for the female side, okay? And those are like infertility labs, the same places where we send them to get semen analyses read, so they drop it off. Those are the same labs where they tend to have an infertility specialist, but those specialists typically only treat females.
Yeah.
And so then they'll refer them to me or myself or another urologist to do the male side evaluation. About 50% of causes of infertility will be just female related. About 30% will be male and female, and 20% will be just male. So that means 50% has a male component to it. So.
I have like a suggestion. So you're in Decatur. I've been to several of the events.
Yeah.
As far as urology, not even just men's health, as far as urology, what don't you do?
I do almost everything.
Okay.
But I gave up the robotic stuff. So,
Okay.
and the reason is because I'm concentrating more on the men's health side. And we have a lot of robotic trained urologists, that did a fellowship just for the robotic training program. So for that reason, I tell patients, look, so for example, if you're gonna remove the prostate, I'd rather have a person who's trained to remove the prostate do it, and have the patient have great outcomes. And then if they have any problems after that, like incontinence and erectile dysfunction, I'll take care of that and make sure that they're back to where they were before, and so thus the overall patient satisfaction improves, patient outcomes improve, everybody does really well.
Okay, so kind of where I'm going with it is that for the seminars for you, I think we should have like a more, I know like erectile dysfunction is definitely a thing for men that affects them, but I think we should also kind of explain to them about what we do as far as urology as well.
Yep,
Scope,
that's
because for our demographic, Decatur, I live in Decatur.
Yeah.
Decatur's middle class to lower class,
Yeah.
to be honest. And so with like the IPPs, they already, as soon as you tell them the price, they're like,
That's true, that's a good point, I think you're right, at the end of the presentation, we should talk about some of the other stuff we can.
But I mean, even if we do tell them the price, which is fine, I mean, we're a yes company, and that's what we try to advertise, but, I think we should make it a big thing to express to them that there are pain points. I mean, because the majority of the people in Decatur, the majority of the people that say yes to even the events don't end up going just because of price.
Yeah.
You know what I'm saying? So, like, I think, sometimes you guys don't want us to explain to them, I make it my business to let the patient know, listen, speak to billing, figure out what your plans are as far as payment, and then let's go from there. Don't just say no, don't just knock it out. Speak to billing and then see where we can get with that. But I just feel like for that demographic, we just need to be a little bit more sensitive to price.
Yeah.
If we can elaborate on that, and then a little bit more broad on what else we do aside from eating. Because even when we did the Golden Corral,
Yeah.
I had a few people that just assumed that we were only handling erectile dysfunction.
Yeah.
I kind of elaborated a little bit more. We do a little bit of everything, you know, we handle this, and this. If you have an issue with, you know, consonants, which is, you know, peeing and the flow variation and things of that nature, we handle that as well.
Yeah, we
So
can
I-
add that to it, but most of the events that we do are centered on one
Right.
type, one
Yeah.
diagnosis, just so, you know, what we advertise is that you come into an event for erectile
Right.
dysfunction.
Yeah, but that's a good
But
point,
that
because a
is-
lot of patients will have multiple issues.
Right.
And so I think Winston made a good point, I should probably put a slide that just shows what urologists do.
It's just like a broad,
Yeah.
it's just like a broad thing so they can understand.
That's great.
So even if it'll create more conversation, so if they have like a question about those little things that you show aside from ED, you can elaborate on it, and that'll probably get some more people to come in. You know what I'm saying?
No,
Because-
good point.
Yeah.
I would like to know when we're scheduling appointments, I think as a group collectively, whoever's answering the phone gets kind of confused as to when a patient calls, it's a female,
Yeah.
if it's a male, and we're like, where do we send them,
Yeah.
who does this, who does that, you know, cause we have a list and it has all of your guys' names on it, and
Yeah.
it says all your specialties. Now we know that, and we're 100% sure now that you are men's health. But when a female calls and has a UTI or,
And go to anyone, including me.
okay,
Yeah, you can still send it to me, you can send it to whoever you want, whoever is the most convenient for them. And I still do, spinal nerve stimulators, both males and females. I still do, hydroextensions for interstitial cystitis. I still do, you treat UTIs and things like that. So you can still send it, if you see, oh, Dr. Shah's available, but, she's a female, let me just send somebody else who's a week out. You don't need to do that.
okay.
You can send it to me as much as you send it to anybody else. It's not a problem.
And then what happens when the patient has an issue where we have to send it to Urogyne and they see you in Decatur, but our only Urogyne is in Alpharetta or Athens?
Yeah.
Do you know if we're getting one that's more centralized to?
Yeah, so I think they're gonna eventually have Buckhead as a
Okay.
location, which will be a nice location, pretty central to every place. And that there may be Marietta or Kennesaw, somewhere around there, another one. So we're having a few offices opening up, and so there will be, maybe sometime this year or next year,
Okay.
we'll have multiple more
Yeah.
central locations. And I think Buckhead for the Decatur location, or even Snellville, may be a better location.
Yeah, because we do, I don't know what the number is, but we do lose some referrals
Yeah.
when we're referring.
Because they have to go that high up.
Yeah.
Yeah, and I talk to patients about, when I talk to them, I'm like, hey, listen, I know you're a gynecologist, it's really great, it's all the way up in Alpharetta, and typically they're open to going there. And I tell them, look, even if they do the surgery and you need to follow up closer, you can always come here afterwards, once you're done following up with them, and a lot of this, but they're just gonna I think they're gonna be a better surgeon for the problem that you have. So they need like prolapse surgery or something like that.
Right.
They'll probably be a better person to send to, and I tell them that, and I tell them, look, but you can always follow up here afterwards once you're done, and you're recovered. And so usually they're pretty open for it. They'd rather go to the best possible surgeon and have the best possible outcome, even if they have to drive an extra 20 minutes, than go to a surgeon where they're not gonna have as good.
I have a question. We get a lot of calls from guys saying, well, I just want to know if I can have kids. Can you help me? What if they want to have kids? How how long does it take for them to find out? What do we do for them?
Yeah, so that's where this whole infertility thing comes in. So the tests, typically an ultrasound, short ultrasound, some blood work, so it's a fertility panel looking at those hormones that kind of drive fertility, and then the semen analysis. Those are the basic starting tests, and that kind of guides us on whether something needs to be done. You'll see guys who had a vasectomy in the past, and now they want to get it reversed because they got a new life, and they want to get back in. Yeah, and then she wants kids. Yeah, so and that's the most common scenario, and I've seen a few of those. And the treatment for that is microsurgery to reconnect it. And I think as of right now, at least as of right now, I'm probably the only one that does that surgery. A new infertility specialist may be coming in, maybe at that point he'll be doing it as well. So, but for those guys, it makes more sense to send it to somebody that'll actually do the surgery. Yeah.
Is there any specific type of appointments you would rather for us to like schedule for you, or appointments that you would not like to be scheduled, or any preference?
You can schedule anything for me. Obviously, I cater to men's health, so ED, infertility, chronic testicular pain, groin concerns. Those are things that are on my alley. But it's not to say that other urologists can't do that stuff too. But if you're ever come across this stuff and you're like, who should I send it to? At least this will simplify that. You can easily just send them my way as an option. So.
Not sure if you guys know Ashley Hayes, the PA. So she works very closely with Dr. Shah as well. So if there's females who want to see a female provider, then we do have her in our office, and she helps both Dr. Carson and Dr. Shaw.
Is she Dr. Patient?
The patient, yes. I'm not sure how her schedule is made up yet, but
yeah, we're trying to get it so she has a consistent schedule now.
Yeah.
And so
It just looks like.
hopefully we get that. Yeah. Hopefully we get that soon. But you can always put them on my schedule, and typically she's with me. And if there's, I had one. I think just recently I had a patient who needed a procedure, it was minor, like cystoscopy or something, and they only wanted a female provider to do it. She did it. What else was the question? Yep.
But, things such as understanding testicles, and, sometimes it's bedwetting and things that pediatric patients have, we see those.
Yeah, that's a good question. So, the undescended testicles, the problem is that they usually require surgery, and we can't do those surgeries because they're young and our anesthesiologist won't let us. I think Carl Pete's the only person that I know that actually does do like some more pediatrics than the average person. I do see, obviously, I have a bunch of patients that have aneurysms, things like that. These are all medically managed. There's no surgical aspect to it, so I tend to see those in clinic, and that's fine. I treat them. So for aneurysms, things like that, you can probably send it to. Again, there are. I think Belani will see them. I'll see them. As long as it's not a surgical thing, and then I do have kids. As long as they're post-puberty, they want circumcision, things like that. We can do them. So you can use that as kind of a guide. So I'd say if they're over 13 or 14, you can probably do them. If they're under and they need something like a circumcision, I'd be wary. They're probably better off just seeing a pediatric urologist. Yeah. So that's the only caveat there. But Dr. Belani and myself, Carl Pete, but Carl Pete doesn't really see patients in clinic. He's more of a nocturnal role. Those, there may be others, but those are the ones. It's weight, but if they're pre-pubertal, circumcision is very different than if they're post-pubertal. Good question, but yeah, if it's a patient that's kind of borderline, you can always, or if it's aneurysm, something like that. I know myself and Belani will see all of them. I don't know. I think the other ones, most of them will say no. I don't know for sure. You can probably ask them. and find out. But,
We're pretty restricted on kids.
yeah,
I
when it
know.
comes to surgery,
Yeah, I don't
surgery.
understand the test because that's a big one.
Yeah, I did a search revision on I think he was like a six-year-old kid. And I did it in the hospital, because, I could do it in the surgery center for the same reason. So there are cases where I'll do it, but I'd say for the patient's sake, I hate giving them a runaround and saying, no, go see this person, go see this person, go see this person. So for their sake, if you can get them to somebody that, and I don't know if there is that somebody here somewhere, but if we can get them to a place where they can actually be seen and then treated appropriately, it's obviously better. But medical things like enuresis, stuff like that, you can always see them. And what I would recommend, and what you guys I think are already doing, is you actually shoot us a text or call us and say, hey, is this a patient that you'd be willing to see? And I've gotten that a couple times, and usually the answer is, yeah, just send them my way. Sometimes the answer is like, I don't think I'll be able to help this person.
I know with torsion, that's big with like kids that play football.
So torsions, you can send them, usually to the ER, but if it's testicular pain, and let's say a kid shows up in our clinic with a torsion, we'll just take him to the operating room and do it. We're not gonna say, oh, okay, go here, go here, go here, we just take care of it. Because that's not something you wanna mess with, you wanna wait on. And so kids like that we'll just do. What else? I'm impressed you guys stayed awake during this time.
Very interesting.
Yes.
Yeah, it was
How is the Venus leak?
Yeah.
How's
Tell
that?
us bothering you.
Yeah, he's stuck
You
on that.
know, I'm gonna ask my questions, so I might schedule.
Yeah.
The Venus leak, how is that treated? So if it is like a Venus leak, what is the treatment for that?
There's no like first aid treatment.
Mm.
You can still try all these options.
Mm.
Sometimes even with a venous leak, injections may be sufficient. So think of the venous leak as a diagnosis.
Okay.
But patients with venous leak are more likely to need a prosthetic to get them to where they want to be than a patient with a venous leak, because the concept is, so injections, medications, all these things do is increase blood flow into the penis. The problem is, even if you have blood flow into the penis and it leaks right back out, you're not going to have a good erection.
Mm-hmm.
So that's the reason why the majority of patients with venous leak are much more likely to go down the penile prosthetic route. That makes sense.
Yeah, I'm there.
What else you guys got?
So Dr. Shaw does accept add-on appointments.
Yeah, and
Please fill his
this is
schedule.
off the record, but, if you see my schedule is full and you have an add-on, just add them on. I don't, okay, it won't be me complaining. The patient needs to be seen, and I have to.
The good thing is that we don't have like a count right now, so it's not like we're kind of questioning, like, did we overbook it? We don't even know,
Okay, perfect.
because.
So don't think twice about overbooking, we just do it, it's fine. Yeah.
And thank you for, the Decatur campaign for the cancellation.
No problem.
I'm sure will help us.
Save Decatur.
Save Decatur. Yeah, our cancellation is a little bit higher than, a lot bit
You
higher.
know, just to touch on what Winston was saying, because I know even at the event that we went to on Saturday, a lot of our patients, they don't even, or potential patients don't realize, they're still thinking that their prostate exam is a physical
Finger.
and we had to tell them, like,
Yeah.
no, you can literally come get your blood drawn. So I think even at the events, if we can kind of bring awareness to, because I even had a lady tell me her husband hasn't been seen since 2007, but he won't come.
Because you think you're sick of it.
Because you think there's a finger up the butt,
Exactly.
yeah.
So I think maybe if we like bring awareness to the community and let them know, like, you guys can literally come in, get your blood drawn, and we can go from there. I think that'll definitely help us.
So you don't have to do that?
No.
See?
No, if PSAs are low, if they're low risk, PSAs are low, I don't do record exams ever. No, it's for prostate cancer. Essentially, the prostate, on the outside of the prostate is where cancer typically is, and the rectum is right next to it. So I can actually feel the outside of the prostate. So if I can feel a nodule, you're worried that it could be a cancer that's kind of starting to bulge out, so we should do something sooner. That being said, it's pretty low risk and low yield if the PSA is low. So, it's reasonable to just get a PSA and kind of go from there, yeah, so.
Yeah, that demographic, they believe they're Spartans and they don't have to do that. There's a lot of naive within,
Yeah.
per se, so that's why it will help if they learn the full spectrum of what we do, then they'll probably be a little bit more involved in going to the actual appointment.
Yeah, we'll start putting up banners, save the prostate or whatever.
They don't know what they don't understand what a PSA is,
Yeah.
they don't want, you know.
Yeah, I mean, we could definitely do more prostate cancer awareness campaigns.
Hopefully we'll be able to start doing more free, PSA screenings. We were doing them and then we had to take them away because there were some process issues within us at AU, so.
Yeah.
hopefully
So
we
I
can have
play
that
adult
start.
softball, and I am telling you that there are tons of older men where I play, and we can wear t-shirts that say "Save the Prostate."
Yeah.
Well,
I will.
that's a good, yeah, if you guys have churches or whatever that you think that we can do,
We
some
do breast
marketing at,
cancer
just reach out to
awareness
me
a lot.
and we'll see if we can
Yeah.
get it set up.
Construction sites
I like it.
What area you in?
I'm in Lawrenceville, but I play in like near Bethesda Park, and then I play in Grayson.
Okay, is that close to Bethesda, is that close to Decatur?
I don't know. Is Grayson close to
I live in
Decatur?
Give me 30-minute drive.
We have different reps. so-
They have different reps, so it won't be.
It's like an
hard.
hour.
Like 30
We
minutes.
do,
Is that far?
that's Alfred Town Hall.
What, Decatur?
Geriatric,
Well, fortunately, we have the Peach Pass that gets us here, and so you can just fly. So Google will say, like, Google told me it's gonna take 37 minutes to get here, it took me 25
Okay.
because of the Peach Pass, you know, so.
Yeah,
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 you're
yeah.
just-
Tell me about that.
Yeah. Alright, what else you guys got?
No, that's
Do you,
it. Except
do you want
for-
anything from us? Like, is there anything that you want us to do or say, or other than, you know, we can go ahead and overbook for you, but is there anything else that you see that we're doing that you want to see us do better at?
I mean, I think you guys are doing a great job. You guys have a tough job. I think it's tough to sell or talk to patients just in general, be the first person to talk to patients about things that they don't feel comfortable talking about,
Yeah.
let alone talk to them on the phone about it. So, hopefully some of this information will kind of give you more things to talk to them about that may kind of relate to them. You know, I think the biggest thing is if you can just get patients to the provider that's not gonna give them the runaround, and nobody gives them a runaround intentionally, but I think that's more on our part, because we're not really giving you a very good list that says, hey, you can send this patient and this person, it's gonna be more beneficial. That being said, all urologists can do at least some degree of all things, right? So, you know, I can do almost anything, as can just about all the other providers. So we all do everything. So it's not unreasonable to send them to whoever. Belani does some penile implants. I think, I don't know, there may be one or two other providers that do it a little bit, and anything complex they send out. But, so it's not unreasonable to send them to a place that's convenient for them, you know,
So it's pretty regular that, the providers at AU refer their patients to another AU provider?
I do, at least.
Okay.
And a lot of them do, so a lot of my referrals are from my own partners. And I, you know, if I think another surgeon can do a better job, I'll send it to them. And, you know, our end goal, at least one of the nice things about AU is we care about patient outcomes and want them to do well and patient satisfaction over just not the concern of losing a patient, which for me has never been an issue. I'm not worried about losing a patient, I wanna make sure they do well, so.
Thank you, Dr. Shaw.
Thank you so much.